This was, I loved both of these talks. This was a fantastic debate, and I'm interested to bring this back to Asia and give, for both sides, I'd be interested to, are there nations that currently recommend IPT for all HIV patients in the region? So we've seen the WHO recommendations. Let's get down to the country level in Asia, and how does this either support or you know, take away from your side? Thank you both.
Thuy first and then Mark.
You know, I haven't had time to do my survey, but Vietnam has taken up this recommendation as of last year. Well, they have talked about this, and there's a lot of concerns among clinicians. There's a lot of resistance against clinicians, just like myself. I struggle with these questions for the cases that I mentioned earlier. And so the recommendation is there in Ministry of Health, but it has been very slowly updated until last year. And now Vietnam Ministry of Health really reinforced it, and everybody gets started on IPT. And some of my patients get the drugs and don't take it. I know in China, last 2 weeks when I travel in China, some program begin to do TST and T-spot testing. Now, T-spot is much better than IGRA for HIV patients. And they did TST and T-spot testing in some places in TB program in China, but not IPT for everybody in China. Those are the only country I know.
Yeah, sure. So, Joe, as you probably know, I mean, pretty much every country has written into the ministry has written into the guidelines that, you know, TST should be offered. Sorry, IPT should be offered to all, regardless of, you know, TST or IGRA or whatever you like. But it doesn't happen on the ground. Yeah, almost extensively. I've had this argument in many countries with many physicians, and basically the excuses are can't exclude TB, engenders resistance. And, you know, I mean, I have to rest on what I presented to you. I think that that's outdated. I think the science is there now that it should be given. And I also believe it should be given whether you're TST positive or negative. Thuy commented that the T-spot is better than IGRA. There's absolutely no evidence for that. I'd like to know what the study is and how it was done. And, I have to answer the question? Okay. I think it can be TST, IGRA, or TB spot. They're about the same, particularly in HIV in terms of excluding TB. And the problem is that people who are anergic don't respond, but they may well be TB infected. And that's why I believe that there clearly is a benefit, survival benefit, to give people TST negative INH. So, yeah, I guess that's my answer.
Okay, Dr. Lee first.
Actually, honestly, I'm on the side of Thuy. For the patients with HIV infection, I think for the prophylaxis, there's one thing for us to very difficult to use IPT because it's so difficult to exclude the active TB. So do you think is any way to exclude those patients with active TB, and then we could use IPT?
Okay, Mark first.
Well, I mean, that was the first objection I dealt with, the difficulty of exclusion. So that very well-performed study in over 30,000 patients, 9,000 of whom were eligible, who had HIV, who were HIV positive. They were, regardless of symptoms and signs reported, they were asked about symptoms of tuberculosis, and that included hemoptysis, fevers, night sweat, cough, weight loss. And they also had mycobacterial culture and a sputum taken for AFP. And TB status was documented. And in that, using a rule of, if you do not have a chronic cough, sorry, a current cough, that's important, current cough of any duration, if you don't have any fevers, if you don't have night sweats, you don't have weight loss, you can, with 98% certainty, exclude that patient as having active TB and offer them IPT.
Very minimum. I just say that it remains very difficult to exclude active TB in patients with HIV, not with those night sweat and weight loss, fever or no fever, just malaise and weight loss, for example. So it's very difficult, but I don't think that should be the main reason driving the argument against IPT.
Dr. Nick?
So I thought this was a no-brainer that Mark win this hands down, backed by WHO policy and so on. I think the difficulty here is that a lot of people are thinking, a lot of people here, clinicians, were thinking individual patient basis, and this is a public health policy. So I think what the statistics have shown is that clinicians can defeat a public health policy by individualizing that. We've kind of overcome that for HIV treatment, but what's going on here is that we're saying here's a policy, but actually we know better in the individual patients. And of course you can risk stratify, and we know that IGRA is a pretty useless test. Right, so that's the problem. We're defeated by the testing technology and by wanting to individualize the best thing for our patients. So I think that the split here, why this question, why Mark should win this, is because this is a public health policy, right? We have to implement that for everyone to catch the people who really ought to have it. Right? Because if we allow clinicians to individualize, it won't happen. It'll happen in 3% and it'll be missed. So I think that's the split here. This is a public health policy, and we have to accept that people have to take that even though the individual won't benefit, because otherwise we can't do anything about the problem.
Dr. Prapan?
In Thailand, you saw the public health policy of our Ministry of Public Health that we have to do IPT. But, for example, in Thailand, even you have a tuberculosis skin test, okay, and we have hundreds of gene expert machine to rule out active TB. Most doctors in Thailand, except me, still refuse to have an IPT. Okay, what are the reasons really behind that? Even the last few months or so, they say, for those who just start on ART for the less than 6 months, these people, may put on ART rather than everyone who are TST positive on ART. So I just wonder, what's your thought on that? What are the real reasons behind that?
Mark?
So unfortunately, Dr. Prapan, in Thailand and also in my country, and I suspect in every other country around the world, doctors are basically witch doctors, yeah? Most of what we do in hospital in Australia with all sorts of tests and funky things, and none of it's evidence-based, right? But people love to behave as if they have some mystical power and they can figure out whether this patient needs X or Y. And despite all the evidence that I think is absolutely screaming that IPT is effective and should be implemented, doctors basically have big egos. Someone else showed a slide here. Doctors have big egos. They think they're actually more clever than the science. It's only that's why clinical researchers are good, because clinical researchers actually use evidence-based medicine to make decisions, not just flipping a coin, which is what a lot of doctors do in all sorts of situations. And in 80% of situations in infectious diseases, there is no evidence for what we do. So it kind of gives us an excuse. But in HIV, one of the great things about HIV is it's really very trial-driven, evidence-driven, because it's only grown up in the era of evidence-based medicine since the early 80s. So I really think it's a doctor problem, as Nick says. Doctors are unhappy to be told what they have to do. They want to make individualised decisions based on their own kind of uninformed notions of who benefits and who won't.
Final comment from Dr. Etzel, or a question.
Like in the Philippines, actually, half of our active tuberculosis is extrapulmonary TB. So I don't know how good the negative predictive value will be there. Or is that for all forms of TB? Because obviously the cough will just be pulmonary tuberculosis. Right. So I don't know how, because we see a lot of hepatobiliary TB, TB adenitis, TB meningitis. So I worry about applying that standard if we're only thinking about pulmonary TB.
Thank you, Dr. Etzel. So final comments now, closing comments. First we'll have Dr. Thuy.
Do I need to be?
No, you can speak from here. It's okay.
I would agree about the issues of clinicians and individualized medicine and the tension between that and public health approach. That will always be there. We're never going to go away. And we should debate it. But what I want to say is that evidence needs to be made here. We did a clinical trial on antifungal therapy in Vietnam that changed treatment behavior at the 5 treatment centers that we did the studies on, because these people actually participate in the studies. They were engaged in the questions, and when the result come out, they understand and implement it. I argue that research needs to be done in this region because there are still questions about the risk for everybody, whether it's the same. And INH resistant, baseline resistant, the regimen, whether INH is better or combination therapy, there's a lot more research need to be done in this region. And that's what I'm arguing for. Going back to Nick's question earlier about, ICRA is useless. I would argue that we, in 21st century, need to go for a diagnostic-driven approach rather than a blanket treatment, mass treatment approach. We are in 21st century arguing for individualized therapy. We even do whole genome sequencing, trying to individualize therapy and spend a lot of money on it. Here we got HIV population with high morbidity and mortality. We should spend money, spend resource in diagnostic-driven approach, scientific diagnostic-driven approach to give the best possible care for our patient, for individual patient. Thank you very much.
Yeah, thanks. So I've very much tried to make my talk an evidence-based talk. And I believe, as I summarise, that the evidence is there now that we should be giving everybody IPT in the Asia-Pacific region. Let me give you some of the reasons. So the first point that Thuy made, and it's an important point, and it's been a long-standing point, is that we shouldn't be giving it to people who are TST negative because there's no benefit for TST negatives. TST negatives will be, in people with HIV, will either be anergic because they're immunodeficient and they don't make a response even though they are latently infected, or they actually won't have been exposed. So that's one of the reasons it's been difficult to show a benefit for TST negatives, because probably half of them actually don't have TB, right? So you need a bigger sample size. But when she showed the meta-analysis showing a clear benefit for TST positives, there was a benefit for TST negatives. It was about 15%, okay? But the confidence intervals cross zero because the sample size, you need a much bigger sample size to show a benefit for those patients, okay? And I think the follow-up killer is that when in Temprano, they gave patients with reasonable CD4 counts, IPT regardless of IGRA result, the mortality benefit was there. Dr. Thuy showed that it seemed she was actually questioning the integrity of the Kaplan-Meier curve because she said it didn't actually show a benefit early, but that doesn't matter. This was a randomised trial. She said, oh, there must be something different about them. This was a randomised trial of 2,000 people, all the known and unknown confounders that might skew the result are completely randomised out, right? This is something that people at the lunchtime capacity building session would learn, right? And so, to me, the science is clear. There was a clear benefit out to 5 years. INH clearly confers a benefit long term, not just for the 6 months, okay? I believe the science of a really highly skilled RCT published in the highest impact clinical journal in the world, probably reviewed by at least 5 people, and it got through. So I'm a believer in science and not kind of objections because it doesn't kind of make sense. I'd rather look at the science and say maybe our common sense needs to change. The other things that were argued was that viral hepatitis and alcohol abuse is problematic in Asia, and therefore people are more likely to get hepatotoxicity. The rates in sub-Saharan Africa of alcohol abuse and viral hepatitis B are about the same. They're about 10%. So if it wasn't shown toxic in studies in sub-Saharan Africa, then I can't see why it would be shown to be more toxic in Asia. I'm absolutely believe in research. I'm not here to say we shouldn't do research, but we need to act, right? Let's implement this. Let's nest research within the implementation. So we haven't dealt with this today, but the next thing coming from WHO, it's already recommended, is instead of giving IPT for 6 to 12 months, we give 12 doses of INH and rifapentine weekly for 12 weeks, which is shown to have the same benefit in HIV positive and HIV negative as 6 months of INH. Why don't we start implementing IPT and perhaps do some randomised trials within the implementation to see whether that's actually gets better uptake than the IPT, which has been so shamefully left out of people's practice, and it's costing lives, right? It's cost millions of lives. We need to do better.
Thank you, Dr. Mark. Okay, so now, unfortunately, for those of you who missed the vote earlier, we'd like to ask you not to vote because you're going to kind of mess up the results, and that wouldn't be fair to our debaters. So if you were late and you didn't vote the first time, please don't vote this time. So the question is, IPT, or the proposition is, IPT should be implemented for all HIV patients in the Asia Pacific. If you are in favor of this, raise your green card. If you are against this, raise your red card. Everybody raise your cards very high, because I'm only so tall, even with this.
Draw? Did anyone change their mind? I think you won.
I don't know.
Can't believe it. I'm going to have to give up.
Higher.
Do
32,
more
33.
research. You have to give up.
You've got to do research. You've got to...
You got.
Okay, so the vote is in. It was very close. We're talking less than 5 votes.
That's a tie.
Less than 5 votes, but the cons win it. Dr. Thuy, congratulations.
Well done.
So I think this is probably, for those of you very much in favor of the public health approach and of looking at this kind of data, quite frustrating. But in fact, this was not that surprising to some of the other people, I think, in this room, based on the fact that 3% of people are getting IPT. But certainly, we need to do better on tuberculosis, whether it's from new ways of diagnostic testing, new ways of delivering prophylaxis, identifying patients, treating patients, keeping them on their TB therapy and ART at the same time. Something definitely needs to change. So, Dr. Thuy, since you won, you get 30 seconds.
I must say that I do believe in IPT. I do believe that you need to start patients on prophylactic and need to implement it now. What I don't believe, don't laugh so soon, is that, again, people who are biologically suppressed, the risk, I think, is the same as normal people, and we need more research in those settings. Okay. Thank you.
So I think certainly a big message of this conference is research is critical to our ongoing response to HIV and co-infections in the region.